Thank you everyone for being here and welcome to today's session. Our Health Equity for Transition Age Youth series is aims to equip pediatric and adult healthcare professionals with strategies to ensure successful healthcare transition for children with special healthcare needs and youth with disabilities. Participants will gain expertise in providing care for patients with disabilities and special healthcare needs, learn how the social model of disability can aid in identifying and addressing ableism within healthcare settings, and strategies to support a successful transition from pediatric to adult healthcare. So before we dive in, we want to kind of describe what makes an ECHO session, what sets it apart from other trainings. In essence, ECHO allows us to move information and not people. It allows you, the participant, to actively learn about a topic and become a resource for your community. Each session, there will be a formal didactic portion on a designated topic, followed by a case presentation. The case presentations offer an opportunity to brainstorm evidence-based solutions, share successes, and receive specialty consultation from subject matter experts. This is an excellent opportunity to learn about new resources and ways to assist your patients. We encourage you to take part in the case presentation group discussions by unmuting or using the Zoom chat, and also think about presenting a case in an upcoming session. We can provide you with more information if you are interested. We aim to create an interactive community, so your participation is key to the success of our ECHO series. We want to create an interactive community where our presenters, stakeholders, and community members all communicate and support each other during a session. So we encourage you to turn on your cameras as long as you're comfortable. And we also appreciate when you're engaged with asking questions in the Zoom chat or by unmuting when it gets time for our questions, especially during the case narratives. The case narratives are the best way to solidify skills learned in the didactics and receive direct advice. So feel free to upload your questions into the Zoom chat and we'll address them at the end of the presentation. As mentioned, we do offer social work and nursing contact hours and CMEs. Please fill out the evaluation after this session, and we will also send you a link to the pre and post test. So now we'll kind of move on to our introductions. I'm Krista Opsdahl. I'm the Project ECHO Director here at the North Dakota Center for Persons with Disabilities. And I will go ahead and kick it over to our hub team members, Jody Patchen.
I am Jody Patchen. I am the project support for Project ECHO.
I am Kyle Erickson. I am the evaluator for Project ECHO. And while I have the mic, so to speak, those of you who said they didn't get the email with the pre-test, I just sent it out again. So if you guys could just confirm you got it, I'd appreciate it. Thanks.
Thanks, Kyle. And I do want to give a shout out to our hub team members. We were working with North Dakota Family Voices, WIND at the University of Wyoming, and the North Dakota Department of Health and Human Services, Special Health Services to create this series. And also thank you to University of North Dakota for providing CMEs for this series. So thank you everybody for being here. And I'm gonna go ahead and pass it over to our presenters, Beth Marks and Yasmina Cisarak. Beth Marks is a research associate professor in the Department of Disability and Human Development at the University of Illinois at Chicago. Sorry, I lost my presentation. She directs research programs related to the empowerment and advancement of people with disabilities through health promotion initiatives and primary health care. She also published numerous articles and books related to health promotion, health advocacy, and primary health care, and co-produced a documentary film entitled Open the Door, Get 'em a Locker, Educating Nursing Students with Disabilities. Also, we have Yasmina Cisarak, who is an Associate Director of Training and Dissemination in the Rehabilitation Research and Training Center on Developmental Disabilities and Health at the University of Illinois at Chicago. Her research interest includes nutrition, health literacy, and health promotion for persons with intellectual and developmental disabilities. Thank you, and please give a warm welcome to our presenters.
Okay, thank you. So let me share my screen, and you'll let me know if you can all see it. Structurally competent healthcare for people with disabilities, the social model. Can you see it? Okay. Yes? No?
Yes, Beth.
Okay.
Yes.
Okay, thank you. So starting the series, our goal is to really present the social model as a backdrop for thinking about structurally competent care. This is just me and myself, and specifically understanding disparities related to structural and social determinants of health, uprooting structural and systemic bias and ableism, and then really starting to think through disability, cultural humility, and access to health for everyone. So I know moving forward, you have other sessions that will go more in depth into all of these issues, but really want to focus on the social model of health and how it impacts how we think about deconstructing and addressing the structural social determinants of health and the barriers associated with those. So thinking about social justice and health equity, always a good place to start is with the Americans with Disabilities Act of 1990. And there's also an amendment act that was done. Whoops, sorry, something has happened. There was an amendment act in 2008, and the amendment act really was meant to go back for the 18 years when the ADA was passed in 1990 to really rethink what we meant about the social model of disability. And unlike the civil rights movement in the 60s and the women's rights movement in the 70s, where we had lots of grassroots demonstrations and rallies to understand what discrimination looked like for people in the civil rights movement and people in the women's rights movement. We didn't have that in the disability rights movement. And in fact, the ADA was passed really quietly in 1990 as a way of getting it through. And so and a lot of the lawsuits that came about from 1990 and to 2008 were based on the medical model. And so within the social model, there's a three-pronged definition. One, a person who has a physical or mental impairment that substantially limits one or more major life activities, a person who has a history or record of such an impairment, and most importantly, people who are perceived as having such an impairment. You only need one of the above three descriptions to be considered a person with disabilities protected from discrimination by the ADA and the Amendment Act. So as noted, the ADA was really, when you look at the text, was meant to, it's based on the social model and was meant to shift our perception of a medical model of disability to a social model. If you haven't read the text of either one of those laws, it's worth looking at them because it provides a nice backdrop. So in thinking about the ADA, we have our internal problem from a medical model. So thinking of people with disabilities as sick, deficient, based on our diagnosis, a mistake, broken, that or a defect. That's the medical model. And the social model really focuses on external barriers. So do people have access to communication, technology, systemic, organizational structure, physical, architectural access, attitudinal access? Attitudinal access is still the number one barrier, and then the disabling environment, and then human rights violation. So that's a kind of a pictorial overview of the medical model versus the social model. Okay. And so next slide. So another thing to think about is people with disabilities, really our family, friends, and neighbors. Within the healthcare community, we still have really a medical view of disability, but in reality, people with disability, and so it's very confined, but in reality, people with disabilities worldwide comprise the largest minority with 16% of the global population. In developing countries, medical advances support more people with disabilities to live. And then the other big piece is that 70 to 80% of disabilities are non-apparent. And so that's a piece where still need a lot of education in supporting the rights of people with disabilities. And again, going back to the social model of understanding that three-pronged definition. And as I mentioned the last one, which is that do people perceive you as having a disability? So like someone who has a severe facial differences from, say, burns, they might have no functional limitations, being able to, take care of themselves, but when they go back out and about in the world, they may have substantial issues in getting housing, employment, education, because of how they're perceived of by others. So disability impacts all of us. The CDC has some really nice infographics, and I think they also have a nice research initiative that looks at how all of us are impacted by disability and the importance of really advocating and being allies for people with disabilities, and how we can create more accessible environments. So just a little overview. Okay, I need to close something. Okay. Between words that we commonly interchange, and they really are not interchangeable. So disability, disease, illness, and identity. Disease is a harmful condition affecting the body, our bodies with symptoms, signs, or anatomical changes, whereas a disability is any condition of the body or mind that may make it difficult for a person with a disability to be able to live, learn, work, play, and love within their community of choice. So that's the importance of kind of thinking about what's in a name. And so I keep getting little messages of people coming in, and so it gets in my way. Okay, just to go back. Okay, there we go. So this slide, today we have a lot more discussion around equity versus a sole focus on equality. And while they sound similar, thinking about equity can result in very different social justice outcomes for people who are underserved, including people with disabilities. In terms of the law, people with disabilities often technically have equal rights, but they are still treated unfairly due to unequal access to resources or opposition from dominant groups who deny them from equal representation while still acting within the law. So when we think about equality, which is the state or quality of being equal, and thinking about quantity, value, or ability, we can see from the 4 identical bicycles given to the 4 people in the top image, that's a state of equality. Everyone has exactly the same bicycle, but it might not actually translate into having equitable services. So equity is defined as the quality of being fair or impartial, or something that is fair and just. So in trying to achieve equity, we're trying to do something in a way that's fair or impartial, and particularly during COVID, when people with disabilities early on found themselves at the top of the list of being denied services. Whoops. Sometimes this has a mind of its own. There's a lot more discussion from all marginalized, underserved groups during COVID around equity and thinking about being fair versus being equal. So structural and social determinants of health, and really thinking about how SFDOH impact disparities and the need to uproot structural and systemic biases by apology, and developing disability cultural humility. So just thinking about how we can start to make those changes for people with disabilities at various points in transition during their lifetime. And so this is a nice image that Yasmina found that I really think provides a nice visual around structural social determinants of health, and how on the left would fish one be safe and happy and healthy if its water were dirty? And if the bowl was cracked and the water was leaking out, how would that really impact fish A's health? And as opposed to fish 2 on the right, if you have a cracked bowl and water is leaking out and it's dirty, can fish 2 realistically ever meet its full health potential due to the water in the cracked bowl? And that goes back to the equity versus equality component, and thinking through the various components of ableism and systemic and structural biases. So just as an overview, the social determinants of health are the conditions where people are born, grow, live, learn, work, and love. So it includes, being able to communicate, neighborhood safety, social support, experiencing discrimination, healthcare access, housing access, food security, stress or weathering over a lifetime, meaning people experiencing discrimination, throughout their lifetime. So really thinking about those touch points that impact people's health over their lifetime. And so this number has changed over the past 20, 30 years. And increasingly, medical care is really a small portion of what impacts health outcomes. 80 to 90% of drivers of health are the social structural determinants of health, and kind of go back to economic stability, healthy food, social connection, education, access, and also neighborhood and built environment. 90% of health, what's spent on healthcare is allocated to medical care. So we really have sort of a disconnect between what are the drivers of health, meaning structural social determinants of health, versus the medical care. Funders like the Administration on Community Living and for people with disabilities are increasingly looking at funding ableism in healthcare. So we are slowly getting there, but important to tuck away as you move forward in thinking about services for people with disabilities. And a lot of kids grow up sort of in isolation of having a disability within the family and peer network. So we have a long way to go to teaching people about their rights and, what ableism looks like. So structural social determinants of health and disparity for people with disabilities. Do people have access to quality health care? Do they have education? Are they taught anything about disability history, disability justice as well? Housing, do people have accessible housing? And then personal safety, do people live in spaces where they can comfortably get out and be able to have healthy lifestyle? Increasingly, especially during COVID, we talk about the double burden. And unfortunately, people with disabilities are often sort of left out of this discussion, but same thing impacts people with disabilities who live at the intersection of all systems of oppression and experience social justice issue. There isn't one issue or one intersection where you won't find, or you will not find disabled people advocating for or experiencing the effect of these issues. Weathering and disparate health outcomes. As I mentioned earlier, weathering really relates to having chronic stress related to biological processes. Ableism is a big thing, just the stress of managing day-to-day access issue is increasingly being recognized as impacting the development of more chronic diseases and impacting people rating of their health and earlier morbidity and mortality issues. People who have multiple underserved identities also experience more weathering. Challenges with healthcare access and care compared to non-disabled people. People with disabilities have more mental distress, more common among women with disabilities, greater among people experiencing poverty, employment, and unmet healthcare needs due to expensive money. And then more violent for women across the board, and especially women with disabilities. This is a nice slide, and pointing back to thinking about social determinants of health, and thinking about moving from downstream issues of what the medical diagnosis is into upstream issues. And so Yasmina found a nice parable for reducing health disparity for people with disabilities, and thinking about two friends fishing on the riverbank when they saw a person struggling in the current. They rescued them. Soon they saw another person struggling. They rescued them too. And finally, the exhausted fishermen decided to go upstream to find out why so many people were falling in, and they discovered a beautiful overlook along the river's edge without any warning signs or protective barriers. Fishermen went to the community leader to report the number of victims they had rescued and explain the connection to the unprotected overlook. The leaders agreed. They ended up installing protective guard and posted warning signs, and preventing the problem saved resources, energy, and lives. So you can see kind of the definition of downstream, upstream, midstream, and upstream. Those are critical to being able to address downstream treatment of a particular chronic condition like diabetes. If we're treating people with diabetes and they don't have access to medication, then we're probably not going to have the benefits of treatment. Increasingly, we are starting to address this in health sciences education. It's a slow process to make those changes, but we're slowly getting there. So I'm thinking about conversation, and this is good for everyone, not just healthcare providers, but people with disabilities and their allies and support, but making sure that people ask about social and health concerns and having the opportunity to brainstorm together, and then referring people. I gave the example of diabetes, but referring people, if they don't have access to a pharmacy, that's like a first step in making sure that people have the benefits and support to be able to get the treatment they need. The American Academy of Family Practitioners, I really like the screening tool. It's called the Everyone Project. They go through, and it's a short screening tool. In Chicago, a lot of the major health providers are starting to ask these questions around housing, food, transportation, utility, childcare, employment, education, financing, and safety needs. But if you haven't seen a form, this is a nice one to use. They also talk about the inclusion of social and health navigators, and thinking through people that can support people with disabilities to access financial, respite care, education, home care, insurance, support, disability resources, mental health resources. And going back to the Everyone Project with the American Academy of Family Practitioners, they have a really cool neighborhood navigator that you can access online. It's interactive. You key in your zip code, and it'll populate. This is one that just happens to be where Yasmina and I work, our zip code, and it populated 4,697 programs related to food, housing, good, transit, health, money, care, education, work, and legal. So I think it's a nice one to have. If your provider doesn't have it, it's good for people, patient or their allies to have it. So in thinking through sort of all of it, and cultural humility, we often put a lot on healthcare providers when it comes to health advocacy, but it really requires all of us to become educated and start the process of amplifying everyone's voices to think about cultural humility. And really love this quote from Jans in 2019, and it's only through the process of transformative education leading to systemic change that healthcare can be rehabilitated into a safe space for people with disability. And again, the notion that healthcare providers can kind of, as we say, heal themselves with some of the processes, I think is a challenge. And very excited that you have your transition program, because I think the younger people that we're seeing coming out of health sciences these days have a very different language and understanding of social justice, and that's a great place to begin. And I think I ended up with enough time if we have questions, or we can go to Paula or Yasmina.
Thanks, Beth. I have nothing to add at this point.
Any questions? Did I cruise through too quickly?
You were very succinct, but it was
You
awesome.
know, I'm always accused of being long-winded, so I'm on a program of reformation for myself.
No, actually, that's perfect. That's the
And
point of.
most importantly, I'm biased. I really wanted to hear Paula.
And I just want to point out, Beth, you had some really fantastic resources in your presentation. We do follow up this session with additional resources from the presentation and notes from our case presentation. So yeah, we will go ahead and pass it over to Ms. Paula Burkhardt.
Well, thank you very much for inviting me to be the case presenter today. I'm excited to share about our experience in transitioning from a pediatric provider to an adult provider. And I'll have Krista share her screen. I just have a couple of slides for a frame of reference so you know who I'm talking about. Currently, I work at NDCBD as a research associate. My primary role, though, is as a navigator, and I help with the health insurance marketplace and Medicaid, and help people enrolled so they can get the health coverage they need. But next slide. My most cherished role is as a mom and a grandma. They call me Mimi. We have 6 children, ranging 30 down to 14, and 4 of those have Down syndrome. And the person that I'm going to be sharing about today is Grace, and she is the one standing in the middle with a gold dress. Grace is 23 years old and is a Spitfire, if some of you know Grace. Next slide. So here's Grace and her siblings. Grace was with the same pediatrician since birth. For over 20 years, he helped. We were on a team together. He was so close to Grace. They had a great relationship. Whenever they were meeting, they'd laugh about Michael Jackson, or he'd talk about her Hello Kitty coloring books. She'd poke him in the tummy, and they just had a really great relationship. And I was honored to be part of their team. She would say, as soon as she'd see him, then, just no blood, no poke, just eyes, ears, mouth, and listen. And I just sit back and watch them do their thing. Historically, our pediatrician would just allow people with disabilities to remain under his care well into their 20s. However, something happened that we weren't expecting. He decided to retire. And so we were not prepared to transition to an adult provider. We did receive several recommendations of possible good providers. So I contacted a variety of them. None of them were taking new patients. So I didn't know what to do. Grace needed to have her own primary care provider. So I thought, I really like my primary care provider. She's so kind and compassionate. She's a family nurse practitioner. So I approached her and I said, Wendy, would you consider taking Grace on as your patient? And she said, yeah, I would consider that. I don't have any experience working with Down syndrome, but I'm open to it. Let me meet Grace. So we went and we met, and they hit it off. And so we started with Wendy as her primary care provider. And it took a few sessions to establish that rapport. But the main reason I went with Wendy is her compassion. She's a foster care mom to teens. I knew she was open to working with people from marginalized people groups. And she was really willing to learn. So I was able to share with her resources that I had used or I had come upon, such as the Global Down Syndrome medical guidelines for caring for adults with Down syndrome. So I gave her that. I would share things in person or through the patient portal. And I knew she was taking this information and putting it to use because I would see that in her care of Grace. I would also share emerging research such as Down syndrome regressive disorder that has become more known just recently. She was very welcome to getting that material and learning the best that she can. So part of being an adult provider for a person with an intellectual disability, or really any person, but with Grace, she needed to establish that rapport. And she did that by asking questions, finding out what Grace was interested in, like Michael Jackson and Hello Kitty and swimming. And she really connected. Grace really responds well to visual, eye contact and smiling and really showing interest. The other thing that Wendy did was allowed Grace, she would ask her a question and she'd allow her to process her answer. She wouldn't just jump in and finish sentences for her or not give her enough time to think things through. So I appreciated that. She would also ask Grace, hey, Grace, is it okay if your mom's in the room with us? And I liked that because it gave Grace a sense of self-advocacy and self-determination in her own care. I knew for sure that Grace would want me there, but I did appreciate that. And that leads into some of the communication. She spoke directly to Grace. She asked questions of Grace, allowed her for that time. She treated Grace as an adult. And Grace, she today says, I am a woman. I'm not a kid. So she appreciated being treated as an adult. Wendy would talk to her in short, clear sentences. She wouldn't use jargon. She didn't shout at her. She used nice communication skills. She would tell her, this is what we're going to do next. Okay, we're going to do this. But she'd also give her some choice, some self-determination. Grace, would you like me to look in your ear first or listen to your heart? So Grace had a little bit of determination in the direction of her appointment. Some other tips for Grace. We knew she has a lot of anxiety about going to the doctor, about being poked or giving blood. And so we would make sure that the appointments would have a longer session, a little bit time allowed for Grace to process things, to get comfortable, but not too much waiting time. And so we'd make sure that the appointment was at the beginning of the day so that she wasn't having that extra waiting time and being more and more agitated, thinking about what may come. We also do the labs right in the room. And so there isn't that lag time or walking now down to the lab. The lab comes in and takes her blood draws. And so that helps. And then we have certain little games that we play just to keep her distracted, like I Spy and those types of things that we do when we go to the doctor. But the biggest thing that you can do as a provider is to presume competence. And that's what I appreciate about all of our caregivers so far, is they presumed that Grace understood, that she had a say, and now she is an adult and she is a woman. And that's what I appreciate, that she gets the care that she needs. And I'm just honored to be part of her team.
Thank you so much, Paula. Do we have any questions? Feel free to put them in the chat, or you can unmute. I didn't realize that you could take labs in the actual doctor's room. How did you go about getting that accommodation?
Actually, Wendy offered it to us. And it's worked out really, really well.
And there's a question in the chat about how working with providers such as female healthcare, OBGYN, and also during puberty.
That's a good question. So when we were working with the pediatrician, he actually referred us to a midwife who then met with Grace and me to decide on how are we going to handle her periods. And so we found out the options from her, and that worked out well. And now as an adult, so far we haven't had any exams in that direction yet. I know that we'll need to do that. But what we decided as a team for Grace, and to this day also, is that she just uses birth control to manage her periods. So she only gets them once a quarter, which is too many.
Can I ask a question? I'm curious what everyone is. It seems like we have a pretty diverse audience, from including providers and healthcare people. I'm wondering what you're seeing as some of your biggest barriers and facilitators in terms of meeting the health needs of people, and particularly people transitioning. That was one question. I have a follow-up question to that too. Meaning, if we could fix one thing, one barrier, what would that barrier be? So the time constraint is a big one. And so there are money and ways out there that providers, and I don't know, Paula, if you've done any of this work, that providers can get paid for more time. I've also have seen providers really shift their practice so that if they know someone needs more time, they put them either at the beginning or the end of the day so that they're not being rushed. And so the strategies around that, and kind of educating providers on making sure that if they have someone who requires more time, that they can get reimbursed for that time. But Paula, have you had any experience?
The only experience I had is when I had, the pediatrician had actual medical home. And so he put that right into his practice, to have an additional 15 minutes. And I don't know if he was able to get, reimbursed for that extra time or not, or if he just did it as part of his practice.
Yeah, I do know from chatting with friends, female friends who have various complex health issues and disabilities, that they themselves have taken the initiative to talk to the provider and have said, like, I will need more time. There was a study in that vein. There was a study that came out, was it 2022, by Lisa Iazzoni and Tara Legoo, that taught, Lisa Iazzoni is at Harvard, Tara Legoo is at Northwestern. The title of the study was, I'm not the provider for you. I think that was the name. And essentially, Lisa Iazzoni is a physician who has a disability, uses a wheelchair, and a lot of her colleagues who were physicians didn't realize that she had a disability, so they were very candid. And have you read that study, Paula? I see you shaking your head. Maybe, Yasmina, you can put the link in. It's well worth reading because the providers were really candid with how they will try to avoid having people with disabilities in their practice. And so I think it's worth knowing about that article, and figuring out how to work with providers so that they don't feel the need to not take care of people with disabilities. Like I said at the last slide, we put a lot on healthcare professional, but to see real change, we as allies, people with disabilities, got to become more knowledgeable on how we can eliminate some of these structural biases. Thank you, Yasmina. At least Iazzoni also, and Tara, once you open that link, they were prolific in getting some really nice articles published during the pandemic. Any other time constraint? Yeah, that's a big one. Any other barriers or any other strategies that you have picked up along the way that are particularly useful? I think, and Emily, Joey, people, can they take themselves off mute or no? If they have a question, I guess actually the direction said raise your hands.
I am not a provider, so this is not necessarily answering your question, Beth. But I was wondering, Paula and anyone else, if you have any inputs of Paula, you did a great job touching on like what Wendy, the provider, did. I was just wondering if there are any other things like the office as a whole when it comes to like the reception and the other nurses, what else they did that made the environment really, accessible and welcoming and inclusive. If there were things that come to mind for you.
I can add, but I'll jump in. And one of the big things is really simple. How may we help you? And do you have any specific communication access needs that you would like for us to use? And then is there any way we can structure the appointment that would be helpful? Meaning, for example, the two big ones, a lot of dental offices are still on second floor lockup, so they're not accessible. But the other, and I know this is an issue in larger cities where people rely on paratransit, and many times that paratransit can be an hour or two late. So is it okay if you show up an hour or two late for your appointment? So that's another disconnect. that often doesn't get adequately addressed. But yeah, back to Emily's question of what are some.
The one thing that I would reiterate is to talk to the individual, not to the person who's with them. Ask them the questions if they need it, and ask if they need assistance. Don't just assume they need it, presume competence, and work from there.
I do want to tag on to that if you guys don't mind. Prior to my role at NDCPD, I was a direct support professional and I supported a lot of people to doctor's appointments. And often I was a sub, so I would support people who I didn't work with regularly and didn't know them very well. And the doctor almost always talked to me and asked me questions about that person. But I remember there was one person that I supported that didn't want me in the doctor's room with them. And I didn't realize that I had to respect that because I wasn't trained to do that. So if we have any disability providers that help with care, maybe letting staff know that, yes, people can attend those appointments without staff if they don't want them there.
And also in that vein, Krista, is if people don't want someone there, how do you prepare someone to go to a visit? And this is everyone. It doesn't matter whether you have a disability or don't have a disability. It's really to plan for that visit as if you're planning for a meeting. So kind of like, what's the agenda? This is why I'm here, so that patients themselves know why they're going, what the top issue is, what any signs and symptoms that they might have. More challenging for people with disabilities who might not have had health education in primary school, or if they had health education, did it include accessible health education, and did it include their disability? So helping people prepare for a visit, whether you're going with them or not going with them, but recognizing the time constraints that realistically exist, and making sure that if you have recommendations, it would be nice if providers would say, you know, what's your diagnosis? What are we going to, how are we going to treat it? And this is, you know, sort of the feedback. What are we going to give you to treat it, and how will this help? A lot of providers don't do that, but I think we as patients can educate ourselves in making sure that when we walk out of the office, we know exactly what we're going to do and what was recommended.
Any final questions or comments?
My final comment is that I forgot to share is that because of the good care that we've gotten, we've moved our whole family over to Wendy. And so hopefully we won't have to transition from a pediatric care to an adult care, and that we'll just be able to stay with this provider for a while.
I was gonna say another thing too is if you you can also think about this when you're dealing with your providers is if you need additional time, is think about the busy times of the day and stuff for practice, because there's natural high busier times in a practice than others. And so, I mean, some practices are busy 24/7, but there's other times when you know there's going to be more of a lull. Like, for example, in the mid-afternoon, oftentimes it's not as busy as, say, early morning. So if you need that extra time, that might be a good time. And you can even ask them when's a quieter time for us to get an appointment, so that we can, because we might need the extra time. I mean, you can always ask. They may not tell you, but you know, and you can always ask to speak to your provider's office nurse to see when it is and talk to them ahead of time and interview them before you go in to actually see them, to see if they're a good fit. You know,
Those are all great suggestions. And I think most providers will tell you, you know, which day of the week is best and which time of day is a better time to go or to make that appointment. And I think if you can sort of ahead of time address some of the issues that you know are issues, I think people are more hard pressed to be, you know, not nice. I'm using not nice in a nice way. There's probably better adjective. But I see, Krista, you put lack of providers in the chat. I think that's another struggle, and I think Paula, you brought up a good point that once you find someone, that someone becomes like the go-to person within, you know, a particular region. And that's the part where, going back to the amplifying everyone's voice, like we really have to, on a systemic level and a healthcare infrastructure level, figure out how we can get more people on board so that it's not just the one person in a community that is doing a good job, because other people do have the capacity, but that's where I think it takes a village approach. So thinking about even your local health department, like how on a community level you can get the community leaders to come together and really go, target, target's not a good word, but really have sort of a strategic plan where you can get more providers that are just accessible, and not just physically accessible, but, you know, in a communication level of being able to talk to people. And going back to something you had said, Paula, and also I think Krista, the other idea when you're supporting people, because I do think healthcare providers, and we're on an interprofessional education project at UIC. It includes nurse practitioners, dental students, and pharmacy students. And we had to, you know, we had transcripts, so we had also faculty moderators, and 100% of the time, the faculty had the darndest thing, and it included people with disabilities as simulated patients. And so they were trained to be simulated patient actors. But when reviewing the transcript, 100% of the time, the people that were saying the darndest things that you thought, like, okay, I don't think I could say that, it was the faculty saying it. And so I think the younger people are getting the memo, but it really highlighted the notion that healthcare providers, you know, don't know what they don't know. But if there's a way of, and I know you have session coming up on ableism and microaggression, to really give people in their toolkit what those look like, and to model, to be able to say to a provider, here's a better way of saying it. Because I think to assume that providers can, you know, as I said, heal themselves and restructure, it's just right at this moment in time, post-COVID, we're struggling to keep people in the profession, and to keep them working as nurses and doctors. So we're in really a health crisis. So I think if we can build that community infrastructure, that's would be really helpful.
And as a provider, ask someone who has a disability to do a walkthrough from the front door all the way back through the exam room. Have them give you some input on improving your practice for people with disabilities.
That's a great suggestion.
We actually do have an ADA expert on our team here at NDCPD, and he's on this call with us right now, Mr. Kyle Erickson. So if you are interested and you're in the Minot area to have somebody come and take a look at your clinic, we can give you Kyle's information and he can provide that service. So thank you for the unintentional plug-in. That was great, Paula. And thank you, Beth and Yasmina, for this excellent presentation. We hope that you can join us for our next session. It's going to be on breaking barriers, strategies for recognizing and addressing ableism in healthcare with Dr. Kathleen Bogart. And thank you guys all for your patience with the pretest not coming through. I think we figured out what the issue is. I'm actually going to I'm going to stop the recording right now.